So now we will move on to the next speaker. Her name is Dr. Daryl Lau, who is a professor of medicine at Harvard Medical School. And she is also the program director of the NIH-sponsored Harvard Hepatitis B Consortium. Dr. Lau? Hello, Dr. Lau, are you available?
Yes, I'm on, just trying to share the screen. Thank you very much for the organizer for inviting me and the kind introduction. Can you see my screen now?
Yes,
okay.
Now we can.
Okay,
Thank you.
I don't want to take more time. So basically, this first slide shows the trend of the worldwide deaths from chronic viral hepatitis. As you can see here, even with effective vaccine and therapy for hepatitis B and cure for hepatitis C, we are actually seeing an increase in death rate from viral hepatitis, and it is projected by year 2040, the death from viral hepatitis will be exceeding the combined mortality associated with TB, HIV, and malaria. So it is remaining a very significant public health problem. And in response to that, WHO in 2017 set up the goals for elimination of viral hepatitis, and it's a very ambitious plan. One of the main goals is a reduction of the new cases of both B and C by 90%. And in terms of the preventive strategy, there are some similarity between hepatitis B and C, but what is unique about hepatitis B is we do have an effective vaccine. It is believed that the universal implementation of the birth dose of vaccine will be one of the major tools to reduce the new cases, but we cannot lose sight in terms of also screening pregnant women, because for the surface antigen positive woman, in addition to giving the vaccine to the newborn, HBsAg is found to be effective. And furthermore, providing the pregnant woman with antiviral therapy during the third trimester of pregnancy, if they have high level of viral replication, is also effective in breaking the chain of vertical transmission. And the WHO actually recommended to use this antiviral strategy last year. And they said that area of the world where DNA is not available, then E antigen status can be used as a surrogate marker. And the other goal of WHO is, besides decreasing the new cases, is the reduction of the number of deaths from a baseline, a 65% reduction from a baseline in terms of hepatitis B, 884,000 deaths in 2015, down to 309,000 deaths. And as Patricia already told us, hepatocellular carcinoma and also complication of cirrhosis are the major cause of death in viral hepatitis. So in order to be able to achieve this very ambitious goal of 65% reduction of mortality, we must accelerate the rate of diagnosis and treatment. And how are we doing? In 2015, only 9% of the infected patients was diagnosed. That's an estimation, of course. And only less than 10% of those patients who required therapy actually got treated. So we have a long way to go in the next 10 years. How can we get to 90% diagnosis and greater than 50% treatment rate? And the WHO did come up with some recommendations for hepatitis B management in the low and moderate and low and middle income countries, basically the resource limited area. And it is a simplified version of the management, but as you can see, it's really still quite complex. WHO does endorse rapid diagnostic tests if it is WHO qualified, or lab-based immunoassay for surface antigen screening. So after you identify the surface antigen positive patients, then you have to see the level of viral replication by DNA test, and also to assess the degree of fibrosis, such as FibroScan, and also AP score, which is a popular score to use AST and platelet for calculation. And we also need to do ALT to know the inflammatory status of the patient. And this algorithm uses cirrhosis for stratify patient for treatment. If the patient have cirrhosis, regardless of their DNA and ALT level, they should be treated. If they over the age of 30, but without cirrhosis, then ALT and DNA will factor into the decision. My concern here is since WHO does not use the E antigen for stratification, I think we may be missing some patients who have E negative disease with viral replication between 2,000 and 20,000 who may have significant disease, but this is another topic of discussion. For those patients with hepatitis B, regardless they are on treatment or not, as Patricia already said very nicely in her talk, then they require HCC surveillance, currently ultrasound plus and minus alpha-fetoprotein, and of course, some of those markers are still necessary to monitor treatment response. So how are we going to be able to reach to as many people as possible, especially in the resource-limited area, to be able to do the screening and evaluation and the treatment? So the point of care approach seemed to be very attractive. Instead of the patient going to the clinic and hospital, we'll bring the technology to them, at least for the initial screening and evaluation. And it would be ideal to have the rapid diagnostic test to give the patient the result right away, whether they have hepatitis B and how severe the disease is, whether they need treatment or not. But in the absence of that, maybe dry blood spots is also a viable alternative to be able to collect the blood on the spot and send it to the laboratory. But WHO have this ASSURE criteria. They do endorse POC, but then if those tests or technology are available, are they affordable? Are they sensitive? Are they specific? Are they user-friendly? Are they robust and rapid? Do they require minimal equipment? And of course, they need to be delivered to those who need them. So this is quite a bit of criteria to fulfill. So what is our hepatitis B landscape in terms of the availability of this point of care testing? Well, we do have rapid diagnostic tests for surface antigen, DNA, nucleic acid testing. They have a lot of promising platforms in development, but none of them are being used or approved. And I'm going to touch upon the application of dry blood spot for this to complement this. And we do have very good portable FibroScan that can provide point of care and portable ultrasound, but it is very operator dependent, as we heard, and require very skilled operator to fully take advantage of that technology. And most of the available surface antigen rapid diagnostic tests are chromatographic immunoassay using either the lateral flow or the flow-through technology. And most of you are familiar with that. So basically, it will have a control strip and a test strip with conjugated antibody on it, and the blood is on one end of the strip. And if the test is positive, then both the control strip and the test strip will be visible. However, there can be indeterminate subjective interpretation of the result, leading to false positive and negative. And this study looked at the performance over 70 surface antigen assays on samples from various HBV genotypes and also surface antigen subtypes. So on the left hand here are the lab-based ELISA assay, but even among the lab-based ELISA assay, that very different sensitivities. Some are really, really good, down to almost zero, and in terms of, or about zero in terms of detectability, the whole way up to about 4.5 IU per ml. And it is critical to realize that these assays, the sensitivities of this assay can differ between genotypes and also surface antigen subtype. So right away, the application of these assays may be different, performed in different regions of the world because of the genotype distribution. Suffice to say that the rapid diagnostic tests as a class tend to be less sensitive compared to the lab-based ELISA tests. But of course, over the years, there have improvement with the rapid diagnostic assays. Here are all the available surface antigen, maybe more that I did not include on this table. And all of them require very little blood volume. That's very attractive, only require finger prick, and also can have the result within 30 minutes, some as short as 5 minutes. And, but none of them are FDA approved, and none of them S2019 are WHOP qualified. Among this list of the rapid diagnostic tests, the Determine and the Vikia assays are the most widely used and also compared and reported in the literature. So I summarize the performance of Determine and Vikia in the literature in the last 10 years. And as you can see, most of these tests are conducted in Africa. And a lot of them are actually tested on HIV positive patients. And you can see the sensitivity can be variable between 69.3% up to 100% for the Determine assay, and 70.7% up to 90% for the Vikia assay. Overall, the specificity of both assays are extremely good, close to 100%. And here may be an issue among HIV infected patients, especially if they are on HIV therapy. And as we know, a lot of the HIV regimen can also suppress hepatitis B. So if they are on treatment with very low level of surface antigen, this rapid diagnostic test may not be sensitive enough to pick up those patients. So we need to be aware of that. The false negative result can occur using the rapid diagnostic test on HIV patients if they are on HIV therapy. HIV itself does not appear to affect the performance of this assay. So the quick summary about the surface antigen assay, as pointed out before, it can be variable in sensitivity in different genotype and HB surface antigen subtype. And the performance can improve, of course, if you use multiple monoclonal antibody and the polyclonal conjugate. And the rapid diagnostic assays as a class tend to be less sensitive than the lab-based ELISA assay. Have to be careful with HIV patients if they are on treatment. And so I think at this point, the surface antigen rapid diagnostic test can be applied for screening because most of the patients before they are on treatment tend to have high level of surface antigen, at least will be over the detection limit of this rapid diagnostic test, but definitely not ideal for monitoring treatment response if we are talking about functional cure. And so in the disease...
So we must be finishing soon.
And okay, in the resource limited area, of course, there can be discounted price for the PCR assay. So in this setting, the dry blood spot may be attractive, and there's definitely advantage of the DBS because it doesn't require much volume, it doesn't require laboratory facility, and it doesn't require cold storage and transport. WHO actually recommended conditionally for DBS for the DNA nucleic acid. And this is a meta-analysis to compare DBS versus serum samples for DNA detection. And overall, the sensitivity is 93% to 100, specificity 70 to 100. the detection limit can be problematic because, as you can see, it's pretty high, between 900 to 4,000. So it's definitely can interfere with interpretation of treatment or monitoring treatment response, and also allocation for therapy. And there are some potential issues, maybe the storage time, the temperature. And I wanted to point it out here. That is an important point. There has no manufacturer validation of the use of this assay with DBS, and they have no guidance on how to standardize the technique to adopt their assays on DBS. And I'm not going to go through this. Currently, we don't have a rapid diagnostic test for hepatitis B, but they are available for hepatitis C and also HIV. So I hope they can be adopted for HBV. We did, with my collaborator, Dr. Dimitri, we actually developed nanoparticle assay, which I would not go into because it's too early in development, but it's an interesting technology. And just a few work about FibroScan. FibroScan is very valuable to assess significant fibrosis and cirrhosis, and it performed much better than APRI or FIB-4 fibrosis score. And it does have limitation because inflammation of the liver and also long-fasting state can falsely increase the score. So I think what the unmet need and urgent need at this point in order to reach the WHO goal of HBV elimination, I think it's very important to establish point of care model in resource limited area. We do have RDTS for surface antigen, but at least standardization. Ideally, it would be nice to have rapid diagnostic tests for DNA and ALT. In the absence of that, standardize the DBS, the dry blood spot may be alternative option to reach out to more people for evaluation and initiation of treatment. Portable transient elastography such as FibroScan is the preferred fibrosis assessment, and surveillance is necessary, but it's nice to have reliable new HCC biomarkers. And so basically, I'm very pleased that recently in the ICE-HBV network, we have formed an international point of care model working team, and I'm very much looking forward to working with all of you to evaluate and also to facilitate the development and recommendation of point of care model as a mean to move the step of HBV elimination forward. Thank you very much.
Thank you so much. This was very informative. We will not be able to take any questions, so please direct any questions you have to Dr. Lau.